Hi, this is Dr. Cliff Gronseth presenting an ultrasound video on the basics of lung ultrasound with regards to COVID-19 virus. As you know, COVID-19 is ravaging the world. If you have access to an ultrasound machine, lung ultrasound may be useful in helping with your clinical decision making. It's easy to learn if you know basic anatomy and ultrasound fundamentals. Realize that the ultrasound is an extension of your physical examination. Like the stethoscope that allows you to listen to the lungs, ultrasound allows you to look inside the body real time. The COVID-19 virus typically affects both lungs in a patchy distribution. Here you can see an X-ray with areas of white consolidated areas next to normal appearing lung. This is classic for the ARDS that develops with COVID-19 pneumonia. The pleura can become irregular and thickened, which is also a finding seen on ultrasound. As the disease progresses, the areas of consolidation get more and more condensed. This causes a whiteout of the lung at the very severe cases. There may only be small little patches in very mild cases, if patches at all. Let's quickly review the anatomy for doing lung ultrasound so you have an understanding of what you might be looking at. There are three main layers. There's the chest wall, which has the muscles and soft tissues, including the ribs. Deep to the ribs are the two layers of pleura. One lines the inside of the thoracic cavity, the other covers the lung itself. The two layers of pleura slide on each other smoothly in a normal lung. With COVID-19 virus, there may be irregularity or even non-sliding of the pleural spaces. Deep to the pleura is the lung tissue. Normal lung is filled with air, so you usually don't see it on ultrasound. We use artifacts to determine if the lung is filled with air or fluid or even consolidated. COVID-19, as I said, oftentimes we'll get both lungs in a patchy distribution. What else can cause shortness of breath? Well, you can have the typical lobar pneumonia, which might be an isolated unilateral consolidation associated with pleural effusions. Congestive heart failure can cause a generalized bogginess of the lungs. A pulmonary embolus that causes a blockage of blood flow to the lung can cause shortness of breath and is usually associated with a normal appearing lung on ultrasound. Pneumothorax, or air between the pleural spaces, can be seen with ultrasound, even better than chest x-ray. There are many other causes for shortness of breath, but in the face of COVID-19, it's important to understand the clinical scenario that you're studying. And first and foremost, remember, don't spread the virus. Protect yourself and the patient. Disinfect the machine before and after use, and never use alcohol on the probes. Alcohol will destroy or ruin the probe face. Refer to the manufacturer's website or manual to define what type of cleaning agent you should use on the probes. How do you do lung ultrasound? You want to approach it in a systematic way. Time and urgency will determine what type of study you do. I find that a low-frequency curved probe is best for doing a lung scan because you can look at the deep structures of the lung along with the superficial pleural sliding. It's important to scan all lung fields, anterior, lateral, and posterior when possible. Examining the patient in a sitting or standing position may be the most accessible, but if the person is lying in bed, you try to reach the posterior lung fields as best possible, maybe having them roll onto their side. Tilting and sliding is going to be key for looking at the lungs, trying to get the ribs in cross-section so you can peer in the intercostal spaces. Depth may change between 5 centimeters up to 25 centimeters depending on where you're looking. Turn off tissue harmonics and compound imaging to enhance the artifacts. Sometimes the machines have features that minimize the artifacts, but in lung ultrasound, you want to maximize the artifacts for interpretation. When you start looking at the lung, it's important to identify the ribs as key landmarks. You can see here the two ribs and the intercostal space between them. Above the ribs are the soft tissues, muscles, and between the ribs you can see a bright hyperechoic line which represents the sliding pleura of a normal lung. Sliding pleura is the first thing you should look for, especially in the superior parts of the lung, the apical regions or the anterior chest if a person is lying in bed, because that's where you will see pneumothorax. There are many reasons to have non-sliding lung appearance, but if you see the sliding lung, that is a first sign of a relatively normal area of lung. Sometimes it helps to lower the gain and increase the contrast so you can see the sliding lung. Notice that this image is taken at about 5 centimeters. When you increase the depth, you'll notice these bright white, horizontal, equidistant artifacts. Those are called A-lines. A-lines represent aerated lung. They develop because of reverberation artifact between the probe and the pleural space. When you see A-lines, it is usually good. It means that the lung is filled with air because air does not transmit sound waves very well. Finding A-lines is the key feature for normal appearing lung in the face of a normal sliding lung. Notice that the ribs cast these dark rib shadows. That way you know you're in the intercostal space. As the lung gets wetter, you might start to lose the A-lines and you develop what's called B-lines. Those are vertical artifacts that extend from the pleural space all the way down to the base of the lung. B-lines represent fluid in the lung and are considered abnormal if more than 2 B-lines are seen in intercostal space. So if you see 3 or more, it is a sign of wetness in the lungs. Here's an example of a B-line extending from the pleural space to the bottom. Notice that it erases the A-lines, and the B-lines will often move with lung sliding. Here you can see multiple B-lines, or lung rockets as they're sometimes called, moving as the pleura slides. This type of lung is likely moist, filled with fluid. A decoy of B-lines is something called Z-lines. Z-lines are also vertical lines that extend from the pleura, but they extinguish. They don't go very deep into the lung space. Certainly don't go down to the bottom of the lung field. Z-lines have no clinical relevance, but can be confused for B-lines. Again, it's important to look for the extension of the B-lines all the way to the base, sliding with the as the lung slides, and erasing the A-lines. As the lung gets wetter, it may consolidate. Here you can see consolidation of the lung. There's a dark, irregular mass filled with small, bright white spots. The white spots are called air bronchograms. They can either be static or dynamic. Dynamic is oftentimes seen in lobar pneumonias, but in this case, this represents static air bronchograms, which are trapped little air lobules that reflect back to the ultrasound probe. You also see what's called a shred sign. Up at the top here, near the pleura, is an irregularity that is classically seen with the COVID-19 virus. Considering that the virus attacks the small air sacs in the periphery of the lung, you may see some subpleural consolidations classically with the COVID-19 ARDS pattern. You also see in this picture a comet tail artifact that looks like a B-line, but it does not originate from the pleural space. So that is simply an artifact within this consolidation. It's important to define the edges of the lung. So you have the ribs on the chest wall, and the inferior part, you have the diaphragm and the abdominal organs. Here you can see a hyperechoic diaphragmatic reflection next to the liver, which, unlike air bronchograms, show dark vessels, not bright white. Deep to the liver, you can see a reflection of the spine. This is normal because the sound waves travel through the fluid of the liver and reflect the spine image back up to the probe. Notice that the spine does not extend above the diaphragm. That's because in this image, the lung at the base is filled with air. Air does not transmit sound waves well, so the signal will come down, reflect off of the diaphragm, make a couple of bounces, then go back up to the probe and record it. That long distance will recreate an image of the liver superior or above the diaphragm. That's normal. It's called a mirror artifact. Using the mirror artifact will confirm air in the bottom of the lung. If you see the spine reflection extending above the diaphragm, it means that there's something reflecting the sound waves above the diaphragm, which would either be fluid or solid. Also notice that you've got what's called a curtain sign in this video. You can see the aerated lung sliding across the probe face, blocking the sound waves from transmitting because, again, sound waves don't travel well in air. They travel well in fluid. So what about other sources of shortness of breath? Here you can see a consolidation in the lung base with some air bronchograms, and you see the spine sign at the bottom. The spine sign is again developed because the sound waves travel through this consolidated lung, reflect off the spine, and bounce back up. Normally, you should not see the lung or the spine. If you see lung at all, it's considered abnormal. Congestive heart failure will cause multiple beelines as the lungs get wet. However, unlike the COVID-19 virus, which is typically a patchy type of pneumonia, congestive heart failure presents as a generalized bilateral lung beeline dominant ultrasound image. It does not have the normal and abnormal patches adjacent to each other because the congestive heart failure will cause a diffuse wetness of the lungs. You can also look for other signs of heart failure by looking at the heart. Look for right heart strain, the contractility of the ventricles, and you may even look for a tamponade, cardiac tamponade, which may cause decreased lung efficiency. Clinically, with congestive heart failure, you may see jugular venous distension, swelling in the legs, and of course, shortness of breath. In a pulmonary embolus, you may have a clinical situation where there's acute onset shortness of breath. This may be from a dislodged clot from the lower extremities that goes up and blocks the blood supply to the lung. You may see a normal A-line pattern of lung tissue when you're doing the scan in a pulmonary embolus. Here you can see A-lines in the intercostal space, as we discussed before. So a pulmonary embolus may have a completely normal appearing lung ultrasound study. However, if you look at the blood vessels in the groin or behind the knee, you may see blood vessels that do not compress. In this case, you can see a compressible vein right here, which rules out a clot in that vessel. A pneumothorax is when air develops between the two pleural layers. Here you can see normal sliding lung. This essentially rules out pneumothorax at that area. Remember, air rises, liquid sinks. Screening for pneumothorax in the high levels of the lung, anterior if they're lying in bed, or in the apical areas if they're sitting or standing, will essentially rule out pneumothorax. If you do not see lung sliding, there are multiple reasons, including possible fibrosis of the lung, poor ventilation. The lung does not slide as much near the hilum or the center of the lung compared to the distal or lower lobes. You cannot rule out a pneumothorax simply by seeing non-lung sliding. However, if you see what's called a lung point, which is where the two pleura actually start to separate because of the air between them, that defines a pneumothorax. There are multiple other sources of shortness of breath: COPD, fibrosis, metabolic disorders. You can use the mnemonic 1, 2, 3 ABC. Number 1, get a good history to help define the potential source of shortness of breath. 2, listen to the lungs. Listening to the lungs will help define areas of potential pathology that you can focus on with the ultrasound. And then 3, use the ultrasound to clarify what type of lung pattern you might see. Is it air in the lungs with A lines? Are there B lines, which represent boggy or bad lungs? Or is it consolidated, C, for parts of the lung that have lost their air? ABC, air, boggy, or consolidated. If you see lung tissue at all, it's abnormal by definition, because the sound waves do not travel in air very well. An aerated lung will stop at the pleural space, and you want to look for lung sliding. The COVID-19 pneumonia causes a patchy distribution in both lungs, with areas of normal lung adjacent to abnormal lung. You can see some pleural irregularities and subpleural consolidations called shred signs at the periphery of the lung. It's important to define the boundaries of the lung, knowing where the ribs are with the rib shadows and the intercostal space, defining the movement of the diaphragm, and defining the abdominal organs. You can use the abdominal organs as windows to see the base of the lungs as needed. I hope this is helpful for you. Thank you for your time.